Welcome everyone. In today's video, we are going to be talking about the anterior Smith-Peterson approach to the hip joint. This approach provides safe access to the hip and ilium. The internervous plane is between the muscles supplied by the superior gluteal nerve laterally and the femoral nerve medially. The superficial dissection is between the Tensor Fasciae Latae, which is supplied by the superior gluteal nerve, and the Sartorius muscle, which is supplied by the femoral nerve. The deep dissection is between gluteus medius, which is again supplied by the superior gluteal nerve, and the rectus femoris, which is supplied by the femoral nerve. Common procedures performed using this approach are open reduction of DDH, pelvic osteotomy, synovial biopsy, total hip arthroplasty and hemiarthroplasty, intra-articular arthrodesis, and excision of tumors. Coming to the technique of this approach. The position is supine position, and if a pelvic osteotomy is planned, we place a sandbag under the ipsilateral hip. The incision is an 8 to 10 cm long incision along the anterior half of the iliac crest up to the ASIS, from where it is curved vertically downwards towards the lateral side of the patella for another 8 to 10 cm. And the subcutaneous tissue is cut in line with the incision. Now to develop the plane between Tensor Fasciae Latae and Sartorius, we have to cut the fascia over these muscles. We palpate the interval between the Tensor Fasciae Latae and Sartorius, which is best identified 4 to 5 cm below the anterior superior iliac spine, and then incise the deep fascia on the medial border of the Tensor Fasciae Latae. Here the lateral femoral cutaneous nerve is at risk because it runs in this place over the Sartorius muscle before it pierces the deep fascia. So we have to identify this nerve and look for its branches. Now once the fascial sheath has been incised, staying within this sheath protects the lateral femoral cutaneous nerves. Now the TFL is retracted laterally and downwards, and Sartorius is retracted upwards and medially. The iliac origin of TFL may need to be reflected to develop this interval. The large ascending branch of the lateral femoral circumflex artery runs in this interval between these muscles below the anterior superior iliac spine. This artery has to be identified and ligated or coagulated. Now we have retracted the Tensor Fasciae Latae and the Sartorius, and we can also see that the ascending branch of the lateral femoral circumflex artery has been ligated. The next plane is between the gluteus medius and the rectus femoris, and gluteus medius has to be retracted laterally, and the heads of the rectus femoris have to be reflected medially. Now rectus femoris has two heads, the direct head and the reflected head. The direct head takes origin from the anterior inferior iliac spine, whereas the reflected head has origin from the superior lip of acetabulum and the anterior capsule of the hip joint, and both the heads need to be reflected. Once we reflect these heads and retract the gluteus medius laterally, we begin to see the capsule. The iliopsoas courses over the medial aspect of the capsule and has to be retracted medially. Now some fibers of iliopsoas originate from the hip capsule and insert inferior to the lesser trochanter. These fibers are known as iliocapsularis muscle. The fibers of this may need to be released to properly expose the capsule. If an exposure of the ilium is required, the muscles from the ilium need to be detached. So here we can see the gluteus medius and the minimus have been detached from the ilium, and then we adduct and externally rotate the limb to put the capsule on stretch, following which a longitudinal or T-shaped capsulotomy is performed and the hip is dislocated by external rotation. Now the desired procedure can be performed and the capsule is repaired following the procedure. Now let us have a look at the structures which are at risk during this approach. two nerves are at risk and one vessel is at risk. The first nerve is the lateral femoral cutaneous nerve or the lateral cutaneous nerve of thigh, which may be injured when the fascia between tensor fasciae latae and sartorius is incised. So before incising, we have always to look for this nerve and any variation in its anatomic course. The second is the femoral nerve, which can rarely be injured if we are straying off course. So the femoral nerve lies anterior to the hip joint in the femoral triangle. So normally this femoral nerve is well medial to the rectus femoris, and if our plane is correct, we will not injure the nerve. If we are in doubt, we have to palpate the femoral pulse, and if we are dissecting in that region, we are way off course and we have to come laterally. The vessel which is at risk is the ascending branch of the lateral femoral circumflex artery, which crosses the operative field proximally between the TFL and the sartorius. So when we are developing the plane between TFL and sartorius, we will encounter this artery. This has to be identified, ligated and coagulated, otherwise it will lead to profuse bleeding. So friends, in this video we discussed the anterior Smith-Peterson approach to the hip joint. It is a very important approach for orthopedic postgraduates and for orthopedic surgeons. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.